Hello, everyone. Welcome back to the Resilient Aging Unfiltered podcast. Today, we have a fantastic guest who I used to work with, Dr. David Shprecher, movement disorders neurologist and exceptional human being. Thank you for being here today, Dr. Shprecher.
Thanks for having me.
Let's jump right in. If you could tell our audience about a little bit about you. How did you end up getting into neurology, movement disorders, and Parkinson's disease?
Sure. So I'm a neurologist. I've been in practice about 16 years now, just focused in movement disorders. So that's all I do is see patients or do research studies that involve my patients with movement disorders. Part of growing up, I was always fascinated with this challenge of understanding not just the meaning of life, but particularly how our brain is responsible for consciousness and making us who we are. So that, along with just the really exciting approach I learned in medical school, where neurology is like being a detective, taking everything we've learned all these years about the brain and all the things that can go wrong and having a list of suspects to figure out what's going on. That really was attractive to me. Once I made that decision to be a neurologist, what also helped me decide I wanted to learn everything I could about one particular area is I kind of realized from doing my required research project, which was just a review on Tourette syndrome, that all these kind of things people always used to ask me why I do or stop and ask me if I was okay were the involuntary movements and sounds people with Tourette's have. So I kind of had to become a neurologist to figure out what I had.
Wow.
So it really motivated me to specialize in that area, but then to be that doctor that could help people get answers a little bit sooner.
Wow. How old were you when you realized that you have Tourette's or you might have it?
I think in my teens and early 20s, I think I might have read the Oliver Sacks books where he talked about the chronic tic disorders.
Hmm.
He talked about patients that tick, or one of them was a neurosurgeon that still had, fortunately, his tics improved when he was in the operating room. So I suspect it was something like that. But I, as a neurology resident, I think I was in my late 20s when I kind of actually volunteered in one of the studies with one of the doctors at the University of Utah and just confirmed that's what it was.
Okay. That's fascinating. I'm sure how do you think it impacts how you interact with patients and families in this space?
Yeah, so it's a balancing act, like with a lot of things. It obviously gives me a lot of empathy for people who want answers that fits their own way of looking at the world. But at the same time, I have to step back and not impose my experience on them because everyone has their own unique experiences, preferences, and goals. But certainly it helps me relate a little bit more to the patient journey.
I bet. Yeah. Well, in this podcast, we focus on resilient aging, and I'd love to talk about Parkinson's disease. I know that's a very big topic covering lots of things and a spectrum. Could you just, for the audience, define what is Parkinson's disease?
Yeah, it's a confusing term because, a lot of your listeners have probably been told you have Parkinsonism,
Hmm.
and now we have to figure out what the cause is. So the way I usually explain that to people is it's a physical symptom or problem where the things that you normally do without having to think about them that are automatic don't come automatically. And you have to be much more intentional about those movements. So, for example, writing, the letters get smaller as you go along the page. If you're scrubbing your hair in the shower and one side is slower, it kind of lags behind the other. When you walk, the arm or leg might not swing or step properly. And in the exam room, we call that bradykinesia. It means slowness of movement. And there are particular features we're looking for to say that that's Parkinsonian bradykinesia. And then we need to see that as well as at least one other feature. So stiff muscles, we call muscular rigidity. And some people feel that as like a tightness or cramping or discomfort, or we might just see it on your exam and might not even be aware of it. And the other is tremor, but it's a specific type of tremor where the arm or leg is fully supported against gravity, but it's still shaking. So someone has at least two of those three features. That's what we mean by Parkinsonism. And we then have to have enough time. So if we have only 5 minutes to see you and then move on to the next patient, it's really not enough time to get the whole story, review the medication list, because certain medicines can cause symptoms that resemble Parkinson's or this Parkinsonism. Even certain occupations, people get metal deposits in their brain from the manganese fumes if they're welders. So we have to ask about all these things. And then there are other features we look for that wouldn't typically be seen with Parkinson's disease that help narrow it down whether it fits with the most common cause of Parkinsonism other than medication, which is Parkinson's disease, or if it fits with another type. And that's where the term atypical Parkinsonism often comes up because it's not the typical features of Parkinson's disease and points to a close cousin.
Thank you. That was great. Very clear. What is the slowness usually one side or the other?
With Parkinson's disease, it's almost always worse on one side than the other.
Hmm.
Very often it's just one side and can stay that way for several years. Whereas with the other causes of Parkinsonism, it often does start on both sides.
So, we think about the motor changes with Parkinson's. What about slowing of thought and even slowing, but of emotional connection? Do you see that? Or, I mean, it's probably not asked about those things, but I'm wondering, yeah, if they come out.
Yeah, it's a really important question because there are a lot of other symptoms with Parkinson's, often that can come before the problems with movement are noticed that are still directly related. And memory and thinking problems and mood changes are definitely included there. They're not as specific to Parkinson's because there are a lot of other reasons people can have them,
Hmm.
but they're a little bit different from the changes people usually notice before they're eventually diagnosed with, say, Alzheimer's disease. So, whereas with Alzheimer's, it's more and more you're forgetting things you should have remembered, like the conversation you just had or something you just read, what happened in the TV program last week.
Hmm.
With Parkinson's, it's more that people can't pay attention. They can't come up with words, particularly names in someone who used to be good at it, and they can't multitask like they used to. And it's a lot more than we'd expect with normal aging, where you just walk in a room, forget why you went there. It seems to be a lot more than we can explain from normal age related changes. And then with mood, people it's hard to separate sometimes if they're depressed or if they just have low energy or they're frustrated by their symptoms. But some people do experience that they're much more prone to getting not just depressed, but anxious. And when they're anxious, they also get irritable. For a lot of men, that's how they express their anxiety is just by having a short temper. So those are kind of the most common. And then apathy is the other one where people are just less motivated to do things and it's out of character for them.
Okay. So, sort of like in Alzheimer's, it can be a number of a variety of mood changes, and they're subtle and or, not, not clearly major depression usually or things like that. And can those happen early on, you were saying?
Sure. Yeah. So these can be early features that then we realize later were related
Okay.
to Parkinson.
So we tend to, and maybe this is an artificial distinction, separate, say, when one has Lewy body disease, it's cognitive changes first, then motor changes. I think, is it a year later or longer? And then vice versa with Parkinson's, motor changes first, then cognition. But sort of what you're saying is that there's different things happening to different degrees, and it's that can make, I would imagine, or you can talk about, does that make precise diagnosis challenging?
Yeah. So there's one area where doctors don't 100% agree yet is whether there's a distinct difference between the two different types of what we call Lewy body dementia. So not 100% of people, but a majority of people with Parkinson's disease, if they live long enough, will eventually develop memory and thinking problems that interfere with everyday activity enough to call it dementia. And we call it Parkinson's disease dementia. But many people have noticed problems more than expected from normal aging from the beginning, often a year or two before their Parkinson's movement problems come up, or at least at the same time as the movement problems. And with that, if they're go on to develop dementia soon after, then we call that dementia with Lewy bodies. And it's an important distinction because unfortunately people usually have a much more aggressive course and they can actually reach an advanced stage even faster than we see with Alzheimer's disease. But both conditions fall under the umbrella of what we call Lewy body dementia. So if they are different, then it would be important for us to understand why some people have a more aggressive course, if there's something triggering that we can do to try to prevent it for future generations, or better ways to treat it to get it to have a more run-of-the-mill course of what we see with Parkinson's. So that's an area, it's more that we call it a Lewy body spectrum disorder, Lewy bodies being just clumps of certain proteins of the brain that aren't being recycled properly that we could see in the brain if someone donates it for research purposes or for the family to get a definite autopsy report that confirms what they had. But that's one area where I think we have good outline criteria the doctors use to all agree when to call it dementia with Lewy bodies and when to call it Parkinson's disease, and then later on Parkinson's with dementia. But there's still a lot of debate about whether there's a true difference.
Hmm.
And in some of those cases where, maybe several years where they're complaining about memory thinking problems, we don't call it dementia for, year two or year three. We kind of debate back and forth what to call that. But it's generally a more aggressive illness.
Hmm. Okay. Do you mind? We tend to talk about Alzheimer's on here. And I'm very familiar with Lewy body disease, but it would be great to hear from you if you just define that too in terms of,
Sure.
yeah.
Yeah. So the more aggressive type, where it's not just Parkinson's for many, many years and then later becomes dementia, the more aggressive type of Lewy body dementia. So dementia because of Lewy bodies in the brain is called dementia with Lewy bodies, DLB for short. It's not a very patient-friendly term,
Mm,
but and many, I think other doctors outside of our clinics do have trouble sometimes and use Lewy body dementia interchangeably with that. But it really refers to someone who has a dementia problem that develops within their first year of the illness and then has at least two other features. So the Parkinsonism we talked about earlier, although in that case, it could just be rest tremor. It doesn't have to be two different things
hmm
like movement that's slow,
hmm
muscle stiffness. It could just be tremor at rest. And then it can be hallucinations that are vision type hallucinations, seeing things that aren't there
hmm
more than once on a recurrent basis, or while deep asleep when having a dream, acting it out on a recurrent basis, not just, once in every 5 years talking in your sleep. And another feature that would check a box, and we have to check at least two of the four boxes, is where they have these spells of profound inattentiveness or disorientation.
hmm
That's not just the sundowning every single night where they're just more disoriented as they get tired, ready to sleep, but can last for hours or even a whole day and at unpredictable times. And if they only have one of those symptom features, they could also have a special test, there's special scans, or even features on a sleep study that will count.
hmm
But it's a much more aggressive illness than Parkinson's and even Alzheimer's. And it seems to also predispose to getting Alzheimer's on top of the dementia with Lewy bodies.
So being a neurologist myself, and knowing, you choose this subspecialty because you want to be around and talk about those specific issues. And there's some movement disorders neurologists that I know that aren't as excited about the cognitive decline and behavioral changes, and maybe don't have the resources and support in their clinic to help people with those. So I'm thinking about people who are on that. So I call it Lewy body disease, and maybe, well, partly because I'm moving away from using the word dementia in general, but so maybe that, for what it's worth. they could be have a hard time finding a home and getting the help they need because they're like overlapping. Do you hear about that a lot?
Yeah. So one of the challenges, even if somebody specializes in movement disorders, they may find themselves in a very busy clinic where there's limited time to go over everything. And so there's a lot more that they can do to fix the movement problems. As we can discuss, there's so many treatments available for the movement problems, but the memory and thinking problems can be a lot more challenging. And it does benefit from having a whole team style approach. So those are patients that often get referred to clinics that have either a team approach or have a little more time to
Hmm.
go over all the aspects.
Got it. Okay. So you just mentioned if we shift to the many treatments that are available for Parkinson's disease. So yeah, can you briefly talk about those and also what are the latest advances and things on the horizon?
Yeah. Yeah. So we have a lot of treatments that can address the motor symptoms of Parkinson's, so slowness, stiffness, tremors, shuffling when you walk. The challenges, those are due to this kind of gumming up the works in the brain of the system that recycles the proteins. So it seems to cause this problem of dying off of cells that require lots of energy. And the ones that require the most energy are the ones that produce this chemical dopamine that's not just important for making you feel good when you win a bet. That's a different circuit of your brain. But it's also a very important chemical that controls movement for those movements that you kind of can put on autopilot. So a lot of the treatment revolves around medicine to either replace dopamine, to act like dopamine, or to control involuntary movements that happen when your dopamine levels are a little above where we want them to be. And so one of the main kind of big developments is we've got longer acting preparations of medicine that's a direct supplement for dopamine. Where it used to be, this doesn't sound like a big deal, but it used to be we had to tell everyone you need to take your pills at least 3 times a day to get a steady dopamine level. And now with the newer ones, it's only twice a day. For someone who's not used to taking medicine often, it's still a big deal. But we also have people where when they get to a point over time, after many years, their brain cells aren't able to store up this dopamine supplement we call levodopa for very long. And so the medicine, whereas it used to last 6, 8 or more hours, or not even wear off if they missed a dose, now it's lasting shorter and shorter, or sometimes doesn't work when it's supposed to. And it used to be that people eventually could benefit from a brain surgery that helps provide continuous effect from the medicine called deep brain stimulation. Now with some of the newer medicines, just time release pills, we can delay that. In fact, this year we've got 2 new approaches to get that continuous effect that work kind of like an insulin pump, where we just you can self apply a little tiny needle with a patch over it and just connect it to a pump. And for people who aren't comfortable with surgery or we're just not comfortable with the risks of the surgery, it can still provide that same effect in place of the deep brain stimulation surgery. So this is all brand new. So I think we already have exciting, therapies that have come out just in the past, less than the past year.
Wow. That's amazing, especially since a lot of folks with Parkinson's are older and would be not great surgical candidates because of other reasons.
Yeah,
Yeah.
yeah, especially in our neck of the woods. We practice in a retirement community.
Hmm. For sure.
Yeah.
Is there a hereditary component to the Parkinson's spectrum diseases?
Yes, most of the time when there is, it's a genetic predisposition. It's estimated that around 10 or so percent of people with Parkinson's have a gene that we know imparts increased risk of Parkinson's. And the most common genes, one of them, it's only like a 10 to 15% risk. But when people get it, they're more prone to memory thinking problems earlier, called GBA, more common in people of Ashkenazi Jewish descent. And the other called LRRK2, it it's not a full 100% lifetime risk, but depending on the type and just where the person's from in the world, the other genes they carry, it can be over 70% lifetime risk, though it might not occur till later in life. And that's one where, another thing we've learned is even people who don't have a gene that we know is a mutation, something happens with that gene in some people where it's still overactive and again gums up the works of that protein recycling system in the brain. So some of our newer treatments are designed to turn down that overactivity of the LRRK2 gene. And we have ways to even pre-screen people to decide if that gene is overactive that are now, being used to test this type of therapy.
And is that that's readily available? Or is that under investigation?
Yeah, so that's a study where people who would like to volunteer in the study can kind of go on the website and look for the study. They call it NEULARK, NEULARK, because it's the NEULARK 2 trial.
Yes. Okay, right on.
Yeah.
What about any difference between men and women, rates of getting these diseases?
Yeah, this is one where it's about twice as common in men as in women.
Hmm.
We don't really know why. There have been a lot of researchers trying to determine, does it have to do with protective effects of estrogen or other hormones? And then investigating whether people who went on hormone therapy would be further protected. We don't have definitive evidence that it's just hormonal influence.
Okay. Got it. Interesting. And I know in Alzheimer's, we have there are some biomarkers available that we can test for now to identify the pathology or, some aspects of the pathology are present in the brain. And what do we have with Parkinson's for that these days?
Yeah. So, biomarkers are a hot topic in the research world. These are special tests that can confirm changes, either, for example, a blood test, even a punch biopsy, a saliva test, or a special scan that actually confirm changes in the body that help diagnose or track the progression of a disease. So how it changes over time. Parkinson's, I mean, one interesting thing is the people who have that Lewy body disease that causes dementia. So Lewy body dementia, at least half, if it's Parkinson dementia, show Alzheimer changes with the amyloid scan. And then with dementia with Lewy bodies, it's even higher. It can be 75% or more in some studies. One of the most common biomarker that's been in use for uh, over 12 years is called the DAT scan. So DAT scan, it's measuring the dopamine transporter, which is kind of something that's in the nerve endings that produce dopamine. So it can indirectly show they're damaged if they don't light up with that scan because it's labeling the proteins that would pick up dopamine after it's released. So that's a scan that can confirm if someone has tremors. If they shake not just at rest, but when they're moving the hands, it helps decide, is it related to Parkinson's or is it just in somebody who has what's called essential tremor that just got worse over time to where there's some rest component. So that's I think a useful biomarker test we've had for a long time. The one that's raised a lot of interest and it's being used in a lot of clinics is a punch biopsy of the skin that looks at the nerve endings in the skin on the back of the neck and the side of the leg. And the same protein that clumps up in the brain called synuclein that's in the Lewy bodies can just be seen under a microscope with special staining. So there's a company that's marketing that test. It's called this SYN-1 biopsy test. And it has been shown to be positive in most people with kind of the very classic presentation of Parkinson disease, dementia with Lewy bodies, and two close cousins of Parkinson's that also would have deposits of synuclein in the brain, but in different areas and not necessarily in Lewy bodies, called multiple system atrophy. And then another one that may start off either with the multiple system atrophy type protein or the Lewy bodies called pure autonomic failure. And the problem we have is it's useful to help rule in Parkinson's disease, for patients where it already fits, so help them be more confident in diagnosis.
Hmm.
But there haven't been studies directly comparing people with these conditions to people with some of the atypical Parkinsonisms. And one of the challenges we're finding in our clinic, people are coming in who clearly have essential tremor or this kind of cousin of Parkinson's, that's a completely different illness called progressive supranuclear palsy, PSP, who have a positive test. And so there's this confusion where without using the history and the exam and really using the well-established way to decide what's the primary cause of their problem,
Hmm.
people are using the test in place of the history and exam and the well-established diagnostic criteria. And we know in people in our brain bank, we have one of the largest brain banks in the world, 2,000 brains donated over 30 years. Our older patients, conservatively 15, 20%, maybe even 30% have synuclein or Lewy body deposits in the brain that didn't actually have Parkinson's disease. And then with Alzheimer's, people have Alzheimer's changes in the brain, probably 40% of them by the time they're over 80. So even an amyloid test
Hmm.
wouldn't change the diagnosis necessarily if someone clearly has dementia with Lewy bodies. So there's all this confusion, even among doctors and nurse practitioners and PAs out there seeing patients, what the test means. And so people still, if they have an unusual presentation, need to see a subspecialist to really help them decide what's going on. Over time, with close follow-up, it's how the illness evolves that really gives us the answer. It's not something where you can give a straight answer, yes, no, like you do with sending a urine sample and yes, you have a bladder infection, no, you don't.
It's really about it behooves clinicians to use that skin punch biopsy test in a much more discerning fashion,
Yeah.
uh, and know who it's indicated for. And so you're seeing people who have essential tremor, who have positive skin punch biopsies. And then so how do those visits end? Do you check in a year, or how does that look usually? And are people I imagine some people are still anxious.
People are still very confused.
Mm,
So, once somebody tells them based on a biopsy test, you have Parkinson's disease, even after, my exam, explaining my background, explaining why I don't think this is Parkinson's, the visit can still end with them saying, okay, but so I have Parkinson's, right? So there's a lot of harm done when a clinician orders the test without explaining the limitations of the test. And yes, I'll plan further follow-up in the clinic and continue to monitor, but I'm not going to tell someone they have Parkinson's if they don't have any Parkinsonism. They just have tremor with activity, which is what essential tremor is. There's no Parkinsonism. I'm going to tell them, look, right now your symptoms are essential tremor. I can't guarantee if you live long enough you won't have Parkinson's,
mhm.
but many people just have deposits of the Lewy body protein in their nervous system that never develop Parkinson's. You might turn out to be one of those.
And we don't have enough, I would imagine, time with this approved skin punch biopsy test to have enough um, autopsied brains to see if what else is going on in these people who, right? Yeah.
Yeah, it really came into common use just in the last couple of years.
Mm,
So
okay.
we will work hard to look for those test reports for people who are enrolled in our autopsy program. But we're rooting for them to live a long time and not all
Yeah.
have to donate their brain right away. So it's going to take several years to have enough people followed in a research brain bank like ours to decide how useful this is in predicting what they turn out to have.
Got it. So it makes me think these tests should really require pre-test counseling by the ordering clinician.
Yeah, it's an interesting problem. So, with genetic testing, that's often strongly recommended, or in some places, even like some clinics even require it, depending on the situation. But this biopsy, just the way it's authorized by the Food and Drug Administration or even covered through insurance, that hasn't really been built in. And unfortunately, even the people ordering the test don't, from my experience, don't necessarily understand the limitation of the test.
Yeah,
So
same with
they couldn't explain
Ultrasound
that.
biomarkers, yeah, for sure.
Yeah.
So a couple things I wanted to jump on, that you mentioned. So can you talk more about the atypical Parkinson's features and things people should know about or look out for?
Yeah. Yeah. And some people are kind of gunning for us to switch from calling it Parkinson plus or atypical Parkinsonism to just say it's a Parkinson's like condition. So it's Parkinsonism, so those motor symptoms, where we believe there's some changes in the brain that are causing it, but it's not due to a medication and it's not due to manganese in the brain, but from welding. And so then we have to put on our thinking caps, be detectives as neurologists, decide who are the suspects. And it can sometimes be a Parkinson like condition that's not due to degeneration of the brain, something called normal pressure hydrocephalus, which you can tell by looking at an MRI or CAT scan of the brain. So we have to get the actual pictures, look at those, and then we can there's a whole process to evaluate that. We can look on the MRI for wear and tear in the insulating material of the brain called the white matter that's supplied by very small blood vessels. That shows up on an MRI, less well so on a CAT scan. And that can also cause walking difficulties that resemble Parkinson's. That's called vascular Parkinsonism or pseudo fake Parkinsonism. And that's more if someone just has trouble walking, but they really don't have a lot of upper body symptoms or the breast tremors. So ideally, that prompts the neurologist to make sure we have a brain scan and to look at it. But then there are times where it's clear there likely is degeneration in the brain, but that it doesn't fit with what we usually see with Parkinson's disease. Two main areas where it points to the next most common cause after the Lewy body spectrum, Parkinson's or Lewy body dementia, is called PSP, progressive supranuclear palsy, where it can start just with severe balance problems and falls. People almost feel they complain of a dizziness because they're so unsteady on their feet. But it doesn't always start that way. So it can start just with a walking problem where the legs freeze up when they walk, like a stutter step called gait freezing. It can start with problems moving the eyes up and down. It can start with just a dementia problem called frontotemporal dementia with language problems. So it's a really complicated thing to diagnose in people who don't see the whole spectrum of PSP and really requires a specialist to look for that. But it's still the most common condition after Parkinson's that's a Parkinson-like condition that is due to degeneration in the brain. So the second most common neurodegenerative cause of Parkinsonism. And then there are some very much less common types, one called multiple system atrophy. So if we hear people have severe autonomic or coordination difficulties, we think about that. So very severe drops in blood pressure, standing up, unexplained bladder incontinence, severe coordination problems. Those are the red flags that make us think about that. And then even less common, something called the corticobasal syndrome, where it's closely related to PSP, but it usually has one side of the body that just doesn't work right,
Mhm.
where they're forgetting how to do things with that arm. So they're losing all the software and
Mm.
circuits in the brain telling them how to do things, or it just kind of cramps up and spasms up, something called dystonia. And then there's all these other rare genetic conditions that can also be Parkinson's like that. It's up to a specialist to figure that out. We don't expect someone who just sees Parkinson's once in a while to know every single condition, but that's where the movement disorder specialty clinics are there to help.
Yeah, and you mentioned the brain bank there. I would love for you to tell the listeners about that, and I'm always promoting that. It's so valuable, and yeah.
Yeah. Yeah. I mean, when I tell people I work at Banner Health, then they get confused with Barrow Neurological Institute because we're both in the Phoenix area. So I have to clarify that. Really, it's interesting. We're all on the batting for the same team, whether it's Banner Health, Barrow Neurological Institute, or Mayo, Arizona. The groups that the people who are currently there were involved in starting this program where doctors have been seeing people since 1998 or so, doing neurological exam, movement disorder exams for people who sign up to be brain donors or to actually donate parts of their nervous system from the whole body. So we call them brain and body donors. And in some cases, we have over 20 years of all this information of their questionnaires and exams, even body fluids or skin biopsies, special scans people agree to. That's optional. And then when they do pass away, we have a call system. So everyone knows about our brain bank all over the world. They don't necessarily know about our clinic, but they all recognize all the publications from this program because we have the shortest time from when someone passes away to when the brain and all the nervous system can be fixed and ready for research. It's just a little over 3 hours. So, as a comparison, other places like, academic centers around the country averages 20 hours. Sometimes it takes a few days to get the brain there. Part of it's because we only enroll people who spend most of their time in Maricopa County, so the Phoenix metro area. And anyone around the world can request parts of that brain or whole body nervous system tissue to use for their research studies. And so there have been hundreds of papers over the years published using the tissue and the clinical information from this brain and body donation program.
Amazing. And so the quickness of studying the brain and body, especially the brain after the moment of death, has to do with it degrades as time goes by and disrupts the actual pathology that was there during life. Is that
Yeah. Yeah. Thank you for the opportunity to explain that. So there are all these different things that scientists would like to be able to measure that unless we can preserve the brain and other parts of the body right away, already degrade. So things like RNA, certain proteins, DNA, all of those things degrade very rapidly. So in those regular brain banks where it can take 20 hours or a couple of days, not only are the tissues degrading where they're harder to diagnose and look at, but even the things that scientists would love to be able to test to really understand the cause of these illnesses just can't be done without this special type of program where we have this call system and you just pick up the phone call as soon as the donor passes away.
that's really amazing and really honors the gift that people are giving with their brains and their bodies at death and creating a constant contribution to science, and that's amazing. Well, thank you for doing that, and I'd love to include in the show notes how people can learn about that and access that. Can you talk, maybe since we're talking about research, can we talk about what other kinds of research studies you have going on there?
Yeah, when it comes to Parkinson's, I mentioned about the research early in the course of Parkinson's, trying to find a way to slow the progression of Parkinson's so that they don't have as aggressive of a course and you get to where they have memory and thinking problems, hallucinations, low blood pressure standing up, walking balance problems that don't respond to medication. There's still a lot to be done with that. So there's a couple of different treatments that are either underway or about to start throughout the country. And so we're mainly involved with two different types of medicine that try to dial down the overactivity of that LRRK2 gene we talked about earlier.
Hmm.
And there'll be others in the works. But I think what's really exciting for us is also, just like you've already done with Alzheimer's, approved at least two treatments that can be started before someone develops full dementia problems from Alzheimer's, but is in kind of a precursor stage, what we call prodromal stage. In the case of Alzheimer's, mild cognitive impairment. With Parkinson's, we're partnering with the Michael J. Fox Foundation to, first of all, try to enroll people to be closely followed that we can confirm have a precursor stage of Parkinson's. And the way that we do that is they can just go to a website, just mysmelltest.org, and then they get sent a kit that tests their sense of smell with a 40-item scratch and sniff test. And impaired sense of smell can be one of the first signs of Parkinson's. Also, acting out dreams while asleep can be a first sign. People who have that are at risk for Parkinson's usually fail that smell test. And people who had difficulty with the smell test then come in for special tests. So another biomarker I didn't really talk about earlier, but that was validated from the earlier version of this study from people that were already followed with early Parkinson's and then with that precursor stage Parkinson's, is actually looking in the spinal fluid that bathes the brain using a spinal tap. And it's not staining a tissue, but it's basically shaking the fluid with a tiny little bit of clumped up synuclein protein. And if there's already a problem in the brain where it's not being recycled properly, then much more of it will clump up. So it's called an SAA for short, or synuclein aggregation assay. And so that's now a big breakthrough from the earlier version of the study that can confirm who has that prodromal stage of Parkinson's, and then to follow them very closely. And by next year, we're hoping to be able to start testing treatments that actually prevent them from getting Parkinson's. So just like, all of us, when we get to be 45 or 50, we can screen for colon cancer and prevent that. We hope to get to where within a generation, we'll have a screening test that's less invasive than a spinal tap, maybe a smell test plus something like a blood test,
Mhm.
and then a treatment that actually can prevent Parkinson's.
Great. Who can get that process going with the smell test? How old do you have to be? Are there any other criteria?
So we've actually cut the age to 40 and over.
Okay,
Yeah, so
good.
you don't really have to be geriatric to volunteer. We know Parkinson's can start um, before the age of 50, even before the age of 40. But currently, we're only enrolling people 40 and over that are willing to do the smell test and then willing to come in for further testing if they fail the smell test.
Okay, great. And again, I'll include all that information in the show notes. So maybe the last topic you could tell us about is Parkinson's prevention, lifestyle things. Is there anything we can do?
Yeah, so lifestyle is really important. So, I've definitely seen, not everyone, but some people where they seem to have very early stage symptoms of something in the Parkinson's family, and their lifestyle measures like diet and exercise and good sleep strategies do seem to make a really big difference. One that also is stress management, which in the case of those patients, it's retiring and moving to a less stressful lifestyle, also has made a huge difference for some of my patients, not everyone. So there's some limited evidence that exercise has a protective effect on the brain. There's also limited evidence that certain dietary approaches may have a protective effect on the brain when it comes to Parkinson's. A Mediterranean style of diet is an example. So it's very challenging to design these studies in a way that's definitive, because placebo effects are so strong. If you believe in something, that actually makes you feel better. But there's still some decent evidence for lifestyle measures, particularly exercise. Like the Nike commercial, just do it. You have to at least find a way to exercise regularly that works for you in the long term. Mediterranean style diet. And then another important is, if you have sleep apnea, to treat it. If you have fragmented sleep, to see what's causing it to be fragmented, where you wake up, can't go back to sleep, can't get refreshing sleep. And everyone's unique in what's causing that, but to work with your healthcare team to address that. And then if you're in a really toxic work environment or relationship, or there's some way to get out of that and get to a less stressful lifestyle, that would be ideal. It's not always possible, but stress management strategies or mitigation strategies in the long term
Mhm.
can be super.
Okay, that's really good to know. I know in Alzheimer's disease, various cardiovascular diseases and risk factors can increase the risk of Alzheimer's and other related diseases years later. Does that fit with Parkinson's at all?
I think that with the diet, there's this kind of lower rate of Parkinson's motor, particularly the non-motor issues that come along with Parkinson's are less likely to develop.
I see.
I think the main thing is just there's scientific evidence that exercise produces chemicals in your brain, releases them so they protect the brain cells in a way
Hmm.
that should be protective in Parkinson's. Not as cut and dry where we can say definitively, people with this type of athletic activity are at lower risk. We definitely know of world-class Olympic athletes that still got Parkinson's. So it's not 100%.
I just wanted to acknowledge that you have been at Banner for 10 years, you said? And you have 5 out of 5 stars with 847 patient reviews. That is so amazing and impressive, and just, of course, says it all right there. And they're so lucky to have you. So I just want to acknowledge that and thank you for all the amazing care that you give patients and families and students and your team members and staff. Everybody really so highly respects you. So thank you for that.
Thank you.
All right. So maybe you can leave us with, final words of wisdom. What message do you want patients, families, healthcare professionals, anyone listening to this podcast in those spaces to take away from your work?
Yeah, I think one important message is there are shades of gray when it comes to diagnosing Parkinson's and related conditions. And so it's really important that patients can find a healthcare team that they're comfortable with, that can follow them up over time to see how the symptoms evolve, because that long term follow up is what really leads to confidence in the underlying cause of the Parkinson's or Parkinson like condition. It's not always a yes no answer. There are always going to be shades of gray. And we do get a definite answer with an autopsy, but we don't have a way to send you that in the afterlife yet. So in the meantime, critical to find a healthcare team that you can get them to communicate, copy each other on your notes, someone that you trust and are comfortable with to have that long-term follow.
Beautiful. Thank you. Thank you so much, Dr. Shprecher, for being here today. Anyone listening on our podcast platforms or on YouTube, please like and subscribe and comment. And if you want to learn more about Brain Love, check us out at our website, mybrainlove.com, and sign up for our email list to learn more. Thank you, everyone. Have a great day.